Welcome, friends. It is our great pleasure to introduce you to SICOT Pioneer. Pioneer is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the world with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Right, a very good morning, good afternoon, and good evening, ladies and gents. I'm Vikas Kanduja, consultant orthopedic surgeon in Cambridge, UK, and one of the founders of SICOT Pioneer. And it's indeed a pleasure to welcome all of you logging into this webinar from all around the world. Now, in the COVID world of non-contact domains, we've certainly embraced digital competitiveness in SICOT with the launch of SICOT Pioneer. And through this platform, we've done over 43 events, and I've had over 70,000 views from 110 countries around the world. So a big thank you for joining in and following us, and continue to do so as well. Now, today's webinar is focused on fragility fractures, and we've decided to do it as a case-based discussion section. I'm ever so grateful to Professor Gershon Wolpin and Professor Roman Pfeiffer, who lead the trauma committee, and to the stellar faculty that they've accumulated for this webinar, who've given up their precious time to come and teach us. And I will let Roman introduce them to you in a minute. We'll try and make this as interactive as possible, so please do post in your questions. And if you can't join us today, then you can access the webinar on our on-demand platform later on. Once again, a big thank you for joining us, and hope you enjoy the webinar. And I'll hand over to Professor Wolpin and Professor Roman Pfeiffer to take the proceedings through. Thank you both, and thank you to our faculty.
Thank you very much for this kind introduction. So we try to cover today really relevant points. Geriatric patients, elderly patients, which probably we need to deal every day with this patient in our praxis. And we actually plan to cover all regions: humerus fractures, spine, pelvis, and of course hip fractures. And we try to discuss it with the cases, so it probably make it more interactive and interesting for you. So the first speaker is Professor Wolpin from Israel, and he's going to introduce cases from focusing the humerus fractures in elderly patients. Thank you very much.
Do you see my slides?
Yes, we see.
Okay, so I'm going to speak about the best treatment for fragility fracture of the proximal humerus. And there is a big debate what to do today with these relatively old people, either to do immediate fixation with total shoulder or partial shoulder replacement, or to leave it as it is. So I want to present another option, which seems to be very attractive, is to try to do a minimal invasive surgery. Now we know that if we do closed reduction or just collar and cuff, this can lead to malunion and shoulder stiffness. And if we go to do open reduction with various techniques, with big plates and everything, this can go and lead to rigid shoulder. And sometimes it would be complicated by avascular necrosis because of injury to the branches of artery that supply the head of the humerus and come from the axillary artery. And we know today that AVN may develop not only by the fracture itself that cause disruption of these branches of vessels, it can become also a bit complicated because of our operation. So this is a fact that we have to think about. So a new item came to the literature 20 years ago and called minimal osteosynthesis. And the meaning is that we do fixation either by percutaneous elements or by open, but with minimal exposure. And this can be with Kirschner wire, external fixator, legs, through rush planes, and intramedullary nailing, and even plate. And for example, you can see here in the picture, it is a big operation, relatively, because it's open, but with minimal invasive procedures like Kirschner wire and only screws. So we had a series of about 200, 290 patients, most of them 55 to 89-year-old, the mean 72-year-old. And this is a follow-up of more than 5.5 years mean. We use the NIR classification that everybody is familiar with that is based on number of the fragments, 2, 3, and 4 fragments, and location of it. And of course, if you have more and more fragments or damage and displacement of the, as we can see here, the meaning is that there is complexity of the fracture. And according to this series, most of our patients belong to 3-part fracture. You see 129, and 4-part fractures, 80 patients in this series. And some of them, 3 of them were in both shoulders. Some of the patients had also fracture dislocation. So you can see that we can do minimal invasive under general anesthesis and image intensifier. And you can see a fracture of the shoulder that was fixed with Kirschner wire, percutaneous Kirschner wire, but we can do it, or here, but we can do it also with intramedullary nail, as one can see here. Sometimes we can arrange even small, low LCP plates, but in severe comminution and displacement, sometimes you have to go to do rigid fixation or to do hemiarthroplasty or total shoulder replacement. And you can see that most of our patients had minimal invasive, almost half of them, about 60 had open reduction, but minimal osteosynthesis, and 51 patients had hemiarthroplasty or total hip, total shoulder. Now, usually prefer to do invasion with Kirschner wire from down to top, and this is following reduction. Sometimes you don't get a good stability, and therefore we have to put 1 or 2 more from above to give it is top of shoulder. And sometimes you do combination between top and down. And I'll see it in a minute. You can see here a lady with percutaneous 3-part fractures. You can see the damage to the head of the humerus in the CT. After reduction and under imaging intensifier, we can see that the fracture was reduced, and we start to put Kirschner wire. It's about 3 millimeters each one inside, as one can see here, until you get very good stability. And then you can add from down another 1 or 2 to give it better stability. And you see this is only operation, you don't have any scar of operation, this post-op. The K-wire are removed usually after 4 to 6 weeks, and then you start physiotherapy. And sometimes if you have fracture with displacement and you cannot do a closed reduction under general anesthesia, there is a method which we use like the joystick of the children. So if you see here, we can't do reduction under anesthesia. You see complete displacement almost of the head. So you use the thicker Kirschner wire are going to serve as joystick. And you can see that with them, we could raise the head and replace it back to its place, as one can see here. Thereafter, we go with a very thinner Kirschner wire of 2-3 millimeters, and we put inside to give it good stability. And then when you have good fixation, you take out the joystick. As one can see here, you can see the joystick still here. We introduce the Kirschner wire, the thinner one, as you have it here, and you get a very good position of the fracture. As one can see here, these are the last x-rays. And this is another case that we did the similar thing. You see the type 4 with comminution, and we couldn't put it back in place. So we took with the joystick, we elevate the head from here back to its place, as one can see here. And then we had this Kirschner wire, and the idea was very successful. We can do also fixation of fractures by screws, as one can see here, percutaneous screws, or to use intermedular nailing. If you use intermedular nailing from above, anterior approach, you have to be careful with the rotator cuff to do small incision in order to introduce it. And you can see that there are some nails with different screws that you can put inside in different directions to give it a better stabilities. And you see this is one of our cases with displacement of the head, fracture of the proximal humerus, and you can see it with the interlocking nail now, anterograde in very good position. We can go on with minimal invasive if you can't do any reduction, and to go with inside screws and tension wire band, as one can see here. But in some cases you can't do it, and you have to go to open reduction and to put plates in order to save shoulder replacement or to leave it. So as I said, with this series, we had a open reduction of about 60 patients, and this was done with K-wire, rush pins, plates, etc. Only 17 with rigid fixation. Miss with K-wire outside percutaneous, K-wire, rush pins, intramedullary lamp, PCP, we had about 150 among 168, and we had hemiarthroplasties versus total shoulder replacement in 51 patients. And this is, for example, a lady that has the closed, the open percutaneous. You see, we had to put it back in place. We opened it, and then we fixed it only with K-wires. And she was very good. Sometimes we use the LCP, as one can see below. And then this is after LCP, you can see very good range of motion of the patient. Following operation, we start with immediate passive and active shoulder exercises and strengthening of the shoulder girdle. And we have also not only CPM of the knee, we have CPM of the shoulders, as one can see here, different direction that CPM is doing. And this is the same patient after reduction and put in place with and this is after removal 6 weeks later and with very good results. So to evaluate the patient, we use the Rockwood modification UCLA or the Chris Constant score, which was my teacher in shoulder surgery in Cambridge once upon a time. And you can see that if you have only 2-part fracture, excellent, a good result with this miss, you can get with 92%. 3 parts, it dropped to 87%, and with 4 parts, excellent, good result only in 67. And this, for example, this lady, you see, reduction, some Kirchner from top and from down, and you see the lady after 1 year, almost full range of motion. Excellent results. We had patients that had both shoulder fractures. Oh, sorry. Both fractures. And they were treated, you see here, with K-wire fixation. This is the left one, and this is the right one. You see good alignment of the fracture. And she is now here 6 months later. You can see almost full range of motion with such combination fracture. And this is another case of a lady that fell from a tree, olive tree. And you can see she had a fracture, simple, yet relatively looking simple, in the right side. This is the left side. In the left side, we succeeded to do close reduction fixation by K-wire, as one can see here. In the right side, we can do it. So we had to open, then we did the minimal invasive with a screw and tension wire band, as one can see here. So this is the patient after operation. Look at the big scar when you have to do arthrotomy and to open the shoulder in order to do reduction. And look here, you don't see anything. So, and this is lady after a few months later, 2-3 years, and she is very happy with the results. You can see the range of motion is almost full in both shoulders. It's a limited flexion of 130 instead of 180, but on the whole, it's looking very good. So, fair and bad result, there were in 15% of closed pinning and 17% of rigid fixation. You see one of the patients with rigid fixation treated with plate. The plate was broken. So we had to go to do hemiarthroplasty after that. Another patient that we did had developed non-union, as one can see here. So we had to do plating after it. But on the whole, we are very happy with that. Just to remind, I said after operation or without any connection to operation, you can have fracture displacement of the head, as one can see here. And look what happened, reduction, very good position. And this is after 9 months, some deformity of the head. Look what's going on after here. And here you see after 2.5 years, severe avascular necrosis and deformity of the head of the humerus. Now, according to the last few years, more and more people go to do hemiarthroplasties or total shoulder, and now the item which is on the sky is the reverse shoulder prosthesis. I think, and this also was described before, that prosthetic replacement of the humeral head in the elderly is preferable to rigid fixation, but we have to remember 2 things. You see, this patient was treated with hemiarthroplasty of the shoulder, and you see he's happy. No pain, almost no pain, but there is limitation in the range of motion. So if you use it, you get a very good relief of pain, but you don't get very good improvement of the range of motion. And I'm very unhappy to tell you that I saw many patients that had reverse shoulder arthroplasty during the last 3-4 years, which became more and more popular. And most of them are happy, no pain, but very decreased range of motion. And this is a patient, just to show you, that had a fracture of the right side treated by Kirchner wires. And then 3 years later, she fell and she had fracture, comminuted fracture of the left one, treated by hemiarthroplasty. And what are the results? She is very happy with the right hand with minimal K-wire fixation, and very unhappy, you see on the face, when I said, please elevate the left one up. So in order to conclude, I think that minimal osteosynthesis, if you can do it, if you know how to do it, and you can do it, it's preferable than to write with, to go and to do open reduction with plates and everything, unless you can do it by Kirschner wire, then you have to open. But then you can do minimal invasive by Kirschner wire, attached wire band, Kirschner attached wire band, leg screw, intramedular nailing, rush pin, percutaneous pinning. It's a very good and safe procedure. And I think this should be the first optional consideration if you have, even in young patient with 4-part fracture, to try. Now, this method is reliable, it's safe, low morbidity rate, and the patient are relatively happy with that. Rigid fixation can give you stable fixation, but you have, because of the severe extensive soft tissue exposure, it may result with high incidence of vascular necrosis, as I saw you before. And now about prosthesis replacement, good pain relief by hemipros, arthroplasty or total shoulder replacement can be achieved in most of the patient, the older patient. However, the gain in range of motion and shoulder function is relatively limited. Thank you very, very much for your attention.
Professor Poppin, thank you very much. In a matter of time, we need to move on to our next speaker. Probably we can discuss in the end. And the next speaker is Professor Savesky from North Macedonia, and he's going to speak about spinal fractures. Thank you very much, Professor Savesky.
Mr. Chairman, dear colleagues, ladies and gentlemen. So my duty today is to talk about surgical treatment of fragility fracture of the spine. Osteoporosis compromises the mechanical properties of the bone, decrease bone density, cortex thinning, and trabecular disruption. This morphological composition changes lead to diminished fracture resistance, fragility, and loosening of the implant. Osteoporotic spine fracture are increasing health problem worldwide, and the population is getting old. This injury are leading cause of pain, disability, morbidity, and impaired quality of the life in the elderly patient. The best treatment is prevention, aiming to identify treatable cases, correct calcium and vitamin levels, and exercise. Medical treatment include hormonal replacement, bisphosphonates, calcitonin, and the conservative treatment include medical treatment, bed rest, braces, and analgesia. Surgical treatment can be done by minimal invasive way, vertebroplasty or kyphoplasty, or open surgery, posterior, usually anterior and combined area approach. MRI is preferable modality of diagnosis and the best contribution for acuity of the fracture by the sign low intensity on T1, high intensity of the T2, and still sequences, compression of neurological structure and local deformities. This one, so 68-year-old female come to us with intractable pain, osteoporotic fracture with a kyphotic deformity. Indication was done to perform vertebroplasty 2 level, thoracic 12 and 11. 2 years later, she lived his normal life. Another cases come to us after 3 weeks, failed conservative treatment, osteoporotic acuity fracture of the thoracic 12, and we make a indication for vertebroplasty in operating theater, looking for the pedicles, and insertion of cannulated needle and injection of the cement. Vertebroplasty was done. The next day, relief of the pain and walking on the department. And after 11 days, after 11 months later, bottoming of syndrome was happened, but there was no severe symptoms to undertake another surgery. So the main goals of the vertebroplasty is pain relief and functional restoration to a degree that patient may return to their activities of the daily living. Bone straightening also is one of the goals. Efficacy 50 to 97%, pain relief. Major complication rate is 0.2. Another change for spine surgeon, a patient with osteoporotic spine fracture who need open surgical treatment, reconstruction, fixation of the weak bones during the fusion procedure. In this patient, bone implant failure is the most commonly result of screw pull out or cut out. So maximizing the bone screw interface is critically important. Various techniques exist to minimize this condition, like extendable of alligator screw, augmented screw. Cement augmentation can be done by open and fenestrated screw. PMMA augmentation has been shown to increase pull-out rate by 150%. Case, patient with osteoporotic spine, no fracture, but after 1 month come to us with an osteoporotic painful fracture with VAS score 8 and paraparesis of lower leg, so neurological deficit. And T1, T2 sequences and still positive, so it is acuity fracture. On the horizontal view, severe degenerative stenosis, which was before diagnostic. So decompression and stabilization with construct and with augmented screw. Also, we do open vertebroplasty by anterior support, which is very important to support the anterior column. X-ray after surgery. Other cases, that is a female also with a paraparesis and a right leg dominantly, MRI acuity fracture, a several all fracture osteoporotic, horizontal view, and we undertake decompression and long construction with augmented screw and prevented vertebroplasty. Other cases, doctor who take a lot of corticosteroids overuse, so he come to us with acute fracture, but before he had several old fractures, so overuse of corticosteroid. We made an MRI acute fracture, a long construct, and fixation with the augmented screw. After 6 months, he do everything. So prophylactic vertebroplasty and long fusion construct achieve and hold better spine alignment and increase segmental stability. So a patient, she were operated for degenerative process of the lumbosacral, and after 14 months come to us with this gibotic deformity, and we do a long construction. Actually, the old fixation, we continue to the thoracic 5. So concomitant anterior fixation, decrease the strain of the fixation construct, increase stability. Cortical screw trajectory from caudate to cephaloid, so big cortical, and from medial to lateral, increase the stability of the construct. Case with osteoporotic fracture, but the radiologist suspicion of the maybe malignant tumor. So she came to us with a SESC score. So MRI compression and kyphotic gibotic neurologic involvement, indication for decompression, corpectomy was done, bone graft instead mesh and plate fixation. After 6 months, she didn't come for the second stage, so we removed the implant and we made long construction with the augmented screw and preventive vertebral plate. So after 2 years later, we do the tibio-calcaneal arthrodesis because impairment of equinovarus of the foot. So vertebroplasty and kyphoplasty have resulted in significant advances in the surgical treatment of this fracture if appropriately indicated. Patients who have neurological deficit, spinal deformity, and intractable pain require open surgical reconstruction with augmentation. Thank you very much. Please fill out our post-webinar survey and receive a personalized certificate of attendance. So don't forget to join us for your next events. Thank you again.
So thank you very much, Professor Savetsky. I think we move on due to the time issues, and I'm going to introduce the next presentation. So thank you very much also from my side. And I'm going to discuss with you about the fragility fractures in pelvis and standards in therapy. And at first I would like to demonstrate some background in epidemiology, classification, and some treatment strategies. So probably you know the epidemiology of pelvic fractures. Fractures have like 3 different peaks. Usually initially they see younger patients with high energy trauma, and we are going to speak today about patients who have fragility fractures. These usually are associated with low energy trauma like fall from stand and another trauma. But if you look for like databases or look at big publication with a focus on polytrauma, you will mainly find here fractures like hip fractures, forearm, spine, humerus fracture. So pelvic ring fractures are somehow underrepresented and not often focused in the studies, especially in the osteoporosis studies. And if you look to the publications, you only actually found like a number like 30 publications per year with a focus on osteoporotic pelvic ring injuries. So this fracture types or this location pelvic ring injury are very often under represented in research, and that's why I would like to stimulate research in this field. So especially elderly female patients have a high risk to have pelvic ring injuries or pelvic ring fractures, like you see on the slide here. There's a high risk with the age, increasing with the age, and also female gender is here as increases the risk for such fractures. So the question is how we should classify such fractures. Probably everybody knows the TIE classification or the O classification, Young-Porter's classification. But usually these injuries or these classification types are associated or related to high energy trauma. You see here on the right side, for example, lateral compression type injuries, where you also see the demonstration of a rupture of ligaments and soft tissues. And this is usually not present in the geriatric patients, which are associated with low energy trauma. So the soft tissues are usually not ruptured like it's shown in this classification, and also not in the tile and the O classification. That's why. So there was a need for a new classification. I think the group of Professor Romans has done a great job to define like fragility fracture types, and using these 245 patients. And there are numerous publications that were already published with a focus on inter-observer reliability, and actually show here this classification system it has a substantial result or very satisfactory. So I would that's why I would like to focus on this classification and introduce a couple of cases from our from some publication, also from our hospital. The initial type of fracture, fragility fracture type A and type 1 and AB, usually anterior fractures. You see it on the left side. It's a bilateral or unilateral fractures, and you see in the X-rays demonstrated here in the pictures. Usually you need to exclude the presence of posterior fracture. Very often it's associated with edema, like here in MRI, and if it's present, you need to discuss probably whether the classification or the fracture type is how they call it, the classification. You change the classification to FFP2, but usually in such cases you perform non-operative treatment, but you very often, if you have present fractures in the front, you need to exclude also fractures in the posterior area. So what about fragility fractures type 2? This is next step of this classification. Usually you have non-displaced posterior ring injuries or fractures. You see in the fracture here on the back side, or a combination anterior and posterior pelvic ring injuries, and or like it's shown here, here's like a comminuted fractures, or here like you see fracture lines. Very often, it's also non-operative treatment. It's enough in this patient, but in some cases, if non-operative treatment and conservative treatment is not successful, you need to try to do like sacroplasties were described, or as eye screw fixation, like it's shown here on the right side, or if you want to stabilize the ventral part of the pelvis, if patient has a pain mainly on the anterior part, you can use Ramo screws or even external or internal fixation to stabilize this region. This is one case from our hospital recently. There's a lady, she's 85 years old. She fell down, and you can see a femoral neck fracture on the left side, and the fracture here with a CT scan on the posterior and the sacrum, and also in the anterior part of the pelvis. So in this lady, of course, she was subjected to a total hip replacement here, and also dorsal fixation, transsacral fixation of the pelvis from the left side. The next type is a fragility fracture type 3. It's usually associated with a displaced unilateral posterior pelvic ring fracture. It can be in the ilium, it can be in this eye joint, it can be in a sacrum, and it is A, B, or C. And usually, so there's a recommendation, of course, initially with conservative treatment, but in the majority of cases, an operative treatment is here recommended. You need to discuss about dorsal and ventral fixation of the pelvis. Mainly, they are percutaneous techniques which are published and recommended here by different authors. Percutaneous fixation, the posterior part of the pelvis, and percutaneous techniques in the front, rods, transsacral fixation, or in the front, in the anterior part, you can use blades, like it's shown here on the right side, or internal, external fixation is also possible. It's one case from our department again. We have a patient 87 years old, and you see a displaced fracture here in the front, and this is it is a minor dislocation, but of like 3 to 4 millimeters on the right side of the sacrum. And so we decided due to severe pain to fix the pelvis here in the front with such a screw of the ramus on the right side and transsacral fixation. And this is a picture after mobilization. You see already here a little bit movement of the screw, but actually it's usually very stable fixation technique and fixation strategy. So the next type is a type 4 fracture, is a displaced bilateral posterior pelvic rig fractures. You see the fractures A is in the ilium, in the sacrum, and also is the anterior fractures dislocated or not. And very often authors recommend here is a need for fixation posterior and anterior. You can use different fixation techniques. The plates, there are probably numerous strategies which can be applied here. So again, one case from our department is a patient 91 years of age. So she is female. She had already numerous fractures, periprosthetic fractures and spinal fractures before and after this fall. She had like this eye joints on the both sides, the fractures on both sides here in the front, so that we decided only to fix here in the back and to let out the fractures here in the front. And so this lady was still happy and could be mobilized within the 1 week. So usually this is the treatment, the flow diagram. The type 1 fractures are usually treated with conservative. Type 2 are only treated surgically if it's not possible and patient cannot be mobilized. In type 3 fractures, usually are recommended to treat it minimally invasive, either with posterior stabilization with screws or rods, and the combination with the anterior fixation. And of course, if you have severe displaced fractures of type 4, you usually focus on open reduction and even spinal pelvic fixation if needed. Patient have a severe pain. So what is the outcome? This is the data published by Professor Roman and his team. Usually you see a reduced mortality in this group in patients who were treated operatively in comparison to conservative groups in this patient group. And similarly, and it was analyzed in type 2 fractures and type 3 and 4 fractures. Both groups seems to profit by operative stabilization. What about the outcome? So the majority of cases have FFP2 and A and C fractures, and fragility fractures type A is most frequent. And you see here that initially the patient had a lot of pain. After fixation, after 3 months, the pain could be reduced, but still many patients still report numbers of pain. And similarly, the mobilization, high numbers initially during 6 months. There's not complete reduction of disability, but still, at least we could reduce their severe cases. So in conclusion, there's increasing incidence of fragility fracture in pelvis. So usually you can perform conservative treatment in type 1 and type 2 fractures. And if patient have severe pain, you can suggest a patient at fixation, percutaneous fixation of the pelvis. Minimally invasive techniques are recommended and safe and reliable usually, and according to the data is which is limited according to my opinion. According to the data, you can even reduce the mortality after 1 year. So thank you very much for your attention, and I hope we can discuss it later. So I think we move on to our next speaker. And the next speaker is Professor Hassani from North Macedonia. And he is going to speak about hip fractures.
Thank you, Roman. Dear ladies and gentlemen, today I will talk about osteoporotic hip fractures. Maybe not presenting so much cases like my Professor Saevsky and Roman, but I will give another view of osteoporotic hip fractures. You know that these fractures, it's a real geriatric epidemic, and the incidence has been doubled till the 1980s, and it's expected to be tripled till 2050. I'll focus on the geriatric osteoporotic hip fractures. And as my understanding, the geriatric, even though in the literature is not defined so good, is the third part of the life. Even this constatation is not so precise and not so polite, but it's true. So if we look at these three types of the elderly, we have, these are my mom and dad. So the last two parts, they should be treated like young persons because they have the expectations are very high. Although these are very important hip fractures, because for almost 1/3 of our geriatric patients, that's the beginning of the end. They are the most contempt fractures and most neglected one, and often operated by the youngest surgeon or residents under supervision. That shows these one of the papers from Norway. There are a huge number that are operated from a surgeon that has less than 3-year experience. They are still often in the shadow of other injured patients, and they are in the same paper shows an interesting fact that they are often subject of non-standard treatment, also in the same center, but also in different hospitals. And there is an inadherence to evidence-based guidelines used in treatment of hip fractures in Norway. Also in Dutch is the same story, published in this publication that I show you. And also paper derived from British National Hip Fracture Database shows the same. So non-permanent following of the guidelines put this patient in a significant risk of inequality in the treatment and for sure in a poor outcome. But Bandhari and Sinkovsky disagree in this rigid treatment, optimal treatment, and they think that the surgeon's personal preferences and beliefs probably should have a major impact in the choice of treatment. In fact, treating this patient is our responsibility. I talk to the patient about osteoporosis, but I never do DEXA scan and I never prescribe drugs for osteoporosis, since it's not my expertise area. That's why we need to involve all the people in the completing our task on treatment of osteoporotic fracture, whether they call geriatricians or internists or endocrinologists or whatever. We are no longer single players in this game. Before, the big chief was responsible to decide almost for everything. Now we are no longer decision makers on our own, even though we are still chiefs in our departments. The decision is quite influenced from other medical and non-medical professionals. This doesn't mean that we are deprofessionalized, but we are traveling from a generalist to a more specialist. This is a time must that we need to adapt, and doctors need to adapt, and others need to adapt in these circumstances. So to complete the treatment, we need a complex approach, and we need a big cooperation between medical and non-medical personnel and the chief and the other artists in this game. That's why we need to know who knows in depth the problem, and we can refer to these persons to decide for a specialist. That's why we need to focus, apart from the technical, our medical investment, we have to do a lot in a team building and team cooperation. If we go back to the hip fracture now, we all know that there is nothing new, that the conservative treatment is almost forbidden. This is a slide from Professor Volpin study, whereas the mortality is quite high, and this, based on these results and other results, the conservative treatment bears a statistically higher mortality risk in geriatric patients, and the operation should be done as soon as possible. So a lot of papers show also that that as soon as possible is done the operation, it's better, it's decreasing the short-term and long-term mortality. Based on these results, early reconstructive surgery of femoral neck fracture in elderly patient is a preferred choice of treatment. That's why, again, I'm coming back to Norway. they have implemented in 2,230 patients the fast track strategy to reduce the excess mortality after treatment of hip fracture that is quite high. And they have seen that 30-day mortality going on the years is decreasing significantly. And that's why, like a conclusion of this part, we insisting on separate orthogeriatric department with standardized treatment and fast track strategy for hip fracture patient, and its implementation is very beneficial for osteoporotic geriatric hip fractures. If we look up what's new in the osteosynthesis, when I started to teach traumatology before 20 years maybe, we have been very satisfied with this kind of implants, the DHS and DCS, but it was only for A1 type of fractures. For A2 and A3, we have seen every second X-ray, post-op X-ray was like this. So we were not satisfied and looking to find a solution of that. We have tried to improvise and to use this kind of intramedullary nails without angle stability to treat fractures. And that was seen that it's not possible to treat this kind of fractures or pseudarthrosis or whatever. Nevertheless, we have tried to do much more perverse things to put so much hardware without any kind of angle stability. This is all from our clinical material. We have, without rotational stability, with planned neck and collapse of the femur, so planned shortening of the femur that nowadays is not more allowed. We have tried to put another screw trying to limit the rotation of this patient. And then we have what we have done for advancing the implant stability. I think that there has been so much done in the science to increase the implant stability and implant strength, whether it is PFNA, wherever it is double screwing of the femoral head or gamma nail or whatever. But what we have done for anchorage of the bone implant to the bone and implant anchorage, we see very much, it's 8% in the literature, cutout rates, and they are always require a complex revision surgery. So what has been done in this direction, if we compare the helical blade and the integrated interlocking screw, we can see that both of them are comparable in varus deformation, and both of them are comparable in femoral head rotation, and both of them are much better than putting only a leg screw in the femoral neck and femoral head. But the science has gone so far. We are using augmentation to enhance the implant anchorage. And this is also from our clinical material. It's augmentation significantly increased the stability of the neck and head fixation comparing with a leg screw and helical blade without augmentation. If we continue to talk about advancement in the treatment of hip fractures, fragility hip fractures of the B type or the femoral neck fracture, then we should think about the osteosynthesis, and we see going from an old-fashioned screw, putting screw in the femoral neck that has no angle stability and no rotational stability and planned neck collapse. We went to a new implant that has been introduced recently, and that recently is not so recently. That's coming from our clinical material. That is not it's quite good video that shows how we do this fixation and how we do compression with a rigid angle stability and with locking screws and with the sliding stabilities, possibilities for compression like you see in the video. And there is anti-rotation ability, and also it's a small footprint with a minimal invasiveness. So Also, the endoprosthesis with partial and total hip replacement is a routine and a long time fighting between the orthopedic surgeons and the trauma surgeon, what is the best. But when my spouse is an immunologist, and we are discussing very often, and she's saying that you are an old-fashioned probably because you are looking at the literature that it's older than 5 years, and they are looking at the literature that is older than 5 only months. So is there something that has been left to do in this direction of advanced mechanical technology? In following all these last seminars, we can see that there is nothing new in advancing the mechanics of the plates and screws and hips and for treatment of fractures of hip. So probably we are very close to the top of this mechanical technology, and probably it's time now to think about changing on moleculars and on other biology, and not only going to do more stronger implants for our future. So thank you very much. We have talked about development of modern fracture care, let's say, of these fractures, following of the guidelines, going from generalist to specialist, but taking again the complete responsibility. I have talked about standardized treatment and fast-track strategy for hip fracture patient, and the question that is open, are we at the top of mechanic technology development and not at the top of molecular or biology development? And we have to do everything to decrease this excess mortality and to enable our beloved oldies to live beside us as much as possible. Thank you.
Thank you very much, Professor Hassani. Very interesting talk. So we move on. Hopefully after all this presentation, we will be going to discuss, have a couple minutes. Next speaker is focusing on a really relevant topic, is periprosthetic fractures of the femur. And speaker is Dr. Georg Osterhoff from Leipzig, Germany. Georg, thank you very much for your presentation.
Yeah, thanks, Roman, for the introduction, dear Chairman. Thanks for inviting me today. I'm going to talk about periprosthetic femoral fractures. Well, we know that the prevalence of total hip replacement, total hip arthroplasty, and total knee arthroplasty has increased during the last decades, especially in the age group of patients aged around 80 years. And at the same time, this is a cohort that has an increasing incidence of femoral fractures. So we have more patients with hip and knee replacements, and we have more elderly patients, and these sustain more femoral fractures. So the result is that we will see a dramatic increase of periprosthetic femoral fractures. And these are defined as a fracture of the femur in presence of either a THA and or a TKA. Most of these fractures actually occur during surgery, so as intraoperative fractures, but we are today going to talk about postoperative fractures, those that happen not due to the initial implantation of the THA or TKA, but later after months or even years. Most of these occur at the femoral shaft, more frequent compared to the distal femur, and only very rarely in the very proximal part, like the greater trunk. If we look at THA, periprosthetic fractures around the THA, then it happens much more frequently in uncemented total hips. This is why many of the registry recommend to go for cemented implantation in elderly patients. And other risk factors are aseptic loosening, which is something we see in almost all of the periprosthetic fractures, increased age, BMI, and of course, an impaired quality of bone. So this is actually what we are going to talk about today. So the goals of treatment are pretty much the same as for just a normal femoral fracture. You want to achieve fracture union, you want to restore the alignment, and you want the patient to be able to return to the pre-injury level of function without pain. But as you have an implant in there, you also want the stability of the implant in the bone, and you need for this, if you have impaired bone stock, you need to restore adequate bone stock. And as these are elderly patients, you want to allow them to fully weight bear as soon as possible. You all know the Vancouver classification. We're going to start with periprosthetic fractures about the hip. So you all know the Vancouver classification with the A type. AG is an avulsion of the greater trochanter, and AL is an avulsion of the lesser trochanter. B1 is a fracture at the level of the femoral stem, where the implant is well anchored in the bone. B2 is a fracture at the level of the stem with a loose stem but good bone quality. B3 is a fracture at the level of the stem with impaired bad bone stock and a loose stem, and a C fracture is one below the tip of the stem. Now, how do we treat them? Usually, most of the greater troch avulsions can be treated non-operatively as long as they're undisplaced. If there is displacement more than 2 centimeters, or this is what we do in our hospital, if there is a functional deficit after you let them walk a bit, or if there is a big osteolysis, then you might, in some cases, go for open reduction internal fixation, although this is really rather a rare thing. Lesser troch avulsions, usually you treat non-operatively. So Vancouver B1 fractures those at the level of the stem, where the implant is still fixed to the bone. This is a fracture you can see extends below the stem, but up to the level of the stem. So in these cases, we usually, like in this 90-year-old woman, do a CT scan. And even here, it's still difficult to tell whether the implant is still fixed. So we usually, if we think it could work, we start with locking plate fixation. And of course, the challenge is to get your screws past the stem, and you need variable angle locking plate systems and cerclages to do this. So what I try to do, as you can see here in an axial view, is I try to get some locking screws in front and in the back of the stem. And if you use cables or cerclage wires, then sometimes it helps to use the cerclage positioning pins that you can attach to most of the periprosthetic plate systems available on the market. But you have to consider that up to 20% of the B1 fractures turn out to be actually B2 or B3 fractures. So with a loose implant, and in these cases, you must have revision arthroplasty in the back end. You must have the expertise, and you must have the implants available, and you go start to do these things. B2 fractures are those with at the level of the stem, where the implant is loose, but the bone stock is good. Here you can go for either for a long revision or femoral stem, and do an open fixation of the fractured fragment, as we did in this case. So this is actually quite a very long stem, but it was necessary in this case, and then we fixed the fragment with wires. In B3, you have a loose implant and bad bone quality. So here you need to add some biology, and this is usually done by a revision stem and femoral allograft, as shown here. In Vancouver C, those can actually be treated just as femoral shaft fracture with a locking plate fixation, but as you again need to get past the femoral stem with your screws, and you need a certain system that has optionality of variable angle screws, and Now we're going to talk about periprosthetic fractures about the knee. So these are the most common classification that you can find in the literature is the SU classification. It divides the fractures again similar to the Vancouver classification in type 1, well above the shield, or the implant type 2 extending until the tip of the shield, and type 3 below the femoral shield. As we have a wide variety of knee arthroplasty, with revision knees being present and being prevalent more and more, we are using this classification described by Fackler and colleagues, which combines the SU classification, or aspects of the SU classification, with different implants. So if we go through these and start with just the surface replacement and a fracture that is above such a surface replacement, you can just go for a plate fixation or intramedullary nail, as you can see here. We prefer to do a nail if we can, and if the box is open of the femoral shield, because where I made this arrow, you can see how this interlocks with the femoral shield and provides extra stability, and these patients can immediately full weight bear. If you have a fracture that extends well below or until the femoral shield, then you can try plate fixation. This is really a borderline case, and our experience is that these tend to often fail. And also, if you look at the literature, then you can see that up to 25% after plate fixation actually fail. So we more and more tend to go for revision knee arthroplasty in these cases. This is another case where we went for a revision knee with long stems, and where we then added fixation around the stems to not have to use a tumor prosthesis like implant. So if you have posterior stabilized fixations, you rather go for plate fixation. If your stem gets longer, you also, in type 1 and type 2, can sometimes try to go for plate fixation, as I did in this case. But as soon as the fracture extends around the stem and to the distal part of the femur, you need to go for distal femur revision total knee arthroplasty, as can be seen here. The same is if you have a distal femur replacement, then of course your distal femur replacement has to get longer. And then there's the special situation that we also see more and more, is that we have kind of interprosthetic fractures. So you have a THA and a TKA, preferably with a lot of cement in the shaft, as you can see here. But in these cases, these behave like a Vancouver C or a Fackler 1. So basically, again, this is just the shaft fracture, and this is how we treat it. But of course, we need to get need to pass the stem of the hip implant again. But this is quite an easy one. Another one, this is a Vancouver C, but it extends to the very long knee arthroplasty stem. So in this case, again, I tried to do a plate fixation, but here I had lots of more trouble to get around the stem. So in these cases, what I sometimes use are these attachment plates. You can attach these to the large plates, and then you have the ability to get some small angular stable screws around the stem. So it is another interprosthetic fracture, but very proximal. So it's basically a Vancouver B1 and a Fackler 1. So again, these we treat like a B1 Vancouver fracture, but extending the plate, overlapping the distal knee implant, as you can see here. And then, of course, you can have superprosthetic fractures like this one. So you have a long revision implant in there, and then you have a fracture that actually, saw this on the CT, it extended into the knee, into the femoral condyles. So there you do not have any options left. And fortunately, this is very, very rare. But in cases like these, you sometimes have to do a total femur. So if you look at the outcome, if you look at periprosthetic fractures around THA, then you see that open reduction internal fixation actually has non-union rates below or up to 10%, which is less than I would have expected, but this is what the literature says. Usually no grafting is necessary with less invasive techniques, so I try to just insert or try to do part of the plate fixation percutaneously. Then you have a good biology. The mortality is actually around 11%. Some studies actually say more, but the large ones say around 11%, which is quite high, but not really for this cohort. Revision total hip arthroplasty compared to open reduction internal fixation has a worse functional outcome than revision for loosening, and potentially a lower mortality compared to open reduction internal fixation if you look at the literature, but the studies are small. If you look at periprosthetic fractures around the knee, then with intramedullary nailing, you can achieve up to 100% union, again, small sample sizes in all of the studies, and you have malalignment with short nails, so you should go for long nails. Locking plate fixation has higher union rates, so if the implant allows, if you have an open femoral shield, then go for intramedullary nailing. And distal femur replacement has revision rates up to 50%. So at the knee, around the knee, try to do fixation. So I can conclude periprosthetic femoral fractures include a wide spectrum of injury patterns from the hip to the knee. The key is to detect implant loosening and to address this appropriately. If the implant is well anchored, if there's no loosening, then you can go for fixation. Usually locking plate fixation is the workhorse. In some periprosthetic knee fractures, you might rather use an intramedullary nail, though. There's different techniques to improve your anchorage of fixation. I showed you some of them. You have specialized implant systems on the market, and whenever you can, try to go less invasive to improve union rates, to allow a better healing with good biology. You should always be able to switch to revision, because often it can intraoperatively it can reveal that your implant is actually used, and in these cases you must have the expertise at hand to switch to revision arthroplasty. The functional outcome in those patients who survive is actually good, but the general morbidity and mortality is high. Thank you.
Thank you very much. So I'm asking SICOT, do we have time for 5 minutes for questions? If it's possible to have it, 5 minutes.
Oh, go ahead.
Yeah, okay. So I just start with the first question, Professor Wolpin. So if you do minimal invasive techniques, this is long K-wires, when do you remove them, and how is your treatment with the physiotherapy? When do you start with it?
I usually remove them after 4 to 6 weeks, and then start the mobilization. At the beginning, I'm doing passive, and then if the patient is okay and relaxed, then we go to active more and more and more. And as you saw, the results are very good in most of the patients when you do it. And I just want to mention one thing that was not mentioned in the 4 first lectures. The most important thing after doing these operations is to send your patient to good endocrinologic advisor, because almost all of them, the elderly patients, are without any anti-osteoporotic treatment. They come to you, most of them, they didn't get any drugs or any help to prevent the osteoporotic, and this is in order to prevent or to try to prevent the second fracture. And we see it usually in the hip fractures. About 10–15% of those that had hip fractures are coming within the first 1 or 2 years with another fracture of the second hip. Another fracture of the second hip, and you have to open the also, and the results of rehabilitation are therefore lower. This is one, and the second thing that I wanted to add that I was very happy to see that in most lectures, except our friend with the periprosthetic, if it is possible, we have to go to do minimal invasive surgery, the results are better. And then you can see it in the spine, you can see it in the hip, you can see it also in the pelvic, where you did fixation with screws instead of plates, or what, whenever it was possible to do it.
Thank you.
So this is a good method.
Thank you. Professor Savetsky, do you perform in every patient an MRI to distinguish between fresh and older fractures?
And imperative, because only with the MRI we can diagnose the presence of acuity of the fracture, because only acuity of fracture is an indication for vertebroplasty.
So, okay. So in conservative treatment, how long do you wait until do your surgery?
Usually the patient comes after 2–3 weeks. So the surgery for vertebroplasty can be done from 3 weeks to the 3 months. No more, because after that it's a chronic fracture, no effect.
Okay, thank you very much. So Professor Hassani, it's a very short question. So do you distinguish, elderly patients are also different, and some of them are more active, some of them are not. Do you have some different like strategy, or do you use different scores how to treat them in the hip fractures, or do you have like similar strategies? So some are active, some not.
Yeah, generally we divide them in 3 groups. But we don't use any score to classify them about the, let's say, activity and biological age. In general, we have like 3 groups, and we say that there are highly active elderly patient. I have had now 85 years old that has fallen from a tree with a pelvic pseudoarthrosis that has been a case that we need to treat really like a young person, because he wants to climb again in the tree. And then we have in the patient in the wheelchair. So, and in the middle is the group, the mostly that are physically active. Thank you.
And Georg, one question from our side. So sometimes I have the difficulty to distinguish between B1 and B2. So you do a CT scan, it's not really clear. Is it fixed? Is it stem or not? How is your strategy? Do you do something different or?
No, so a standard is CT for sure, and you need to talk to your radiologist to get metal artifact reduction sequences or also for CT, and that usually helps. But very often, as you saw in my cases, it's difficult to decide. So this is what you sometimes, rarely what we do is if we really want to know. And we do traction radiographs. So you do a little bit of traction, do an X-ray, and then you can compare the X-ray before and that under traction. And if you see a difference, this is a very low cost and good solution. But sometimes it can be a bit painful for the patient. So and as I said, up to 20% of the fractures turn out to be loose, even though in the CT and on the X-ray you think it was fixed. So this is you have to have the availability to convert to revision arthroplasty. What also can help you is to have radiographs from earlier. So we call the hospitals where the patients were before, and we ask them for the pictures from 5 years ago if they're available. And if you then see a difference, then that helps.
Professor Volpin, yes.
Yeah, I want to ask George because I didn't mention in my discussion. In cases of distal femoral fracture, Robocop 1, meaning in the distal third, you spoke about intramedullary nailing. Which type you're doing, antegrade or retrograde?
Retrograde.
Okay, because I have very good experience with the retrograde femoral nail. Very short operation, very good for the patient, safe, without any problems.
Absolutely, absolutely. Minimal invasive, best union rate. So if that is possible, if you have a femoral shield where you can get your nail through, then it's the optimal solution.
What's about distal femoral fractures following total hip? Did you try retrograde nail?
No, in these cases we don't.
So I did few cases with retrograde nail. I put the nail up to the almost touching the distal stem, and also very good results after it.
Yeah, okay. I'm a bit afraid about the shear stresses at both tips.
I said short distance between them. You don't have any electric problems. These are nail of similar metals, etc. Try it once, you'll see. It's taking half of the time.
Good. I will.
Any comments or?
Just to remind one thing, Roman, to the whole audience. We had a guarantee from the SICOT journal to publish a paper all together, all the 5 of us, about the fragility fractures. We don't need to pay any money for that. First time in SICOT that I heard the history, and I'm many years in SICOT. So those of you that want to join us, I think should write a paper of 2 pages, let's say, in large abstract with pictures showing whatever you want to say and conclusion, and we can join it together. I'll ask Roman to be the first author. Okay, Roman?
Professor, we can discuss it later because we're still online, you know.
No, but this is SICOT journal. So you'll start with that and everybody else will join you. And add these parts, so we'll have a nice paper in the SICOT journal about fragility fracture of this webinar. So those of you who agree, please call Roman and join him, okay? Apart from him, thank you very much. I'm very happy to congratulate Roman. He replaced me this year as the chief chairman of the Trauma Committee for another 2 years. So I wish you all the best, Roman, with that. You'll get any support from me, of course. And I'm responsible now from SICOT on the specialty trauma cluster that will be always on the first day of the Congress, Wednesday. And we have to build it already. So thank you very much to come and to present in my behalf. Roman, you want to conclude anything?
No, I just would like to thank everybody, all speakers. I think these were very interesting presentations, and we see each other in the Congress. Thanks.
Those we will live. Okay, bye-bye, everybody.
Bye-bye.
Thank you.
Thank you.
Nice to see you all again.